Okay, so today, we have lots of people. We're going to go over Barium Enema. What I'm going to do is start, and I'm going to go through the whole procedure, well, most of the procedure, through all the positioning before I stop. I'm not going to stop at showing you the positioning initially, because I want you to see a pattern flow of taking the cassette in and out. So if you check off in this room for the BE, you'll be actually swapping out the cassette every time, because I want you to see a flow pattern. The biggest thing with the BE is how much time it takes. The positions, I think you will find, are really not that difficult, other than the decubitus takes a little time to set up, but it's all KUB, rotate, KUB. It's like doing lumbar spines and sacrum and coccyx with no collimation. So it's really not that bad. So I'm going to go through the whole thing. Once I finish positioning for the decubitus, which is the last image, I'll stop, show you the decubitus, go through all the positioning, then I'll come back and finish up with my patient. Okay? So it's going to be kind of in a weird order, but I just want you to see a flow pattern on how to do asking questions and pulling a cassette out and bringing another cassette in and getting a flow pattern going. Anybody here not seen a BE? Okay, so you know the biggest thing is that people want it to be over. And like people are trying to hurry.
I'm scared they're going to blow.
So that's why you want to have a good flow pattern. So that's what the goal is to show you how to do that. Obviously, when you really do it for checkoff, we're going to slow you down a little bit because we have to check every image. But we want to see that you know how to ask a question while they're positioning and be, you know, and doing some of those kinds of things. So. All right. Is that? Hey. Hi. My name is Gina. I'm going to be in on your exam today. Would you come with me? I will. Okay, Miss Utz, could I check your armband, please? Can you repeat your full name for me? And your date of birth? September 12, 1951. Okay, and I see here that you're here for a barium enema. Is that correct? Okay. What kind of problems have you been having? I have been bleeding. Oh, how long has that been going on? 4 months. 4 months, okay. Changed it to 4 months today. I thought 4, but it feels like 4 months though. All right. Well, have you ever had this exam before? I have not. Okay. Did you take your prep last night? I did. Okay. Do you feel like it worked pretty well? It's supposed to clean you out pretty well. I think you did. Okay. We'll take one image before we get started just to kind of take a check on that too. Okay. Have you had anything to eat or drink today? No. Any chance you could be pregnant? Okay. And do you have a latex allergy? I do not. Okay. That's good. All right. Have you ever had a barium enema before? So let me explain it to you a little bit. Go ahead and have a seat. I'm going to do it before she changes her clothes, because she changes mine.
Yeah, there are people that do that.
Yeah, they do. Yeah. And have they already changed their clothes? I'm just curious.
Oh, no.
They tell them all before they change their clothes?
Yeah.
Just in case.
I would change my mind.
I wasn't sure. Okay, so what we're going to do today is I'm going to have you change into a gown before we get started, but I'm going to take one image first to see how well that prep works, like I mentioned to you. I'll show it to the doctor, and he'll tell us if we can proceed or not. Okay. Then I'll be inserting an enema tip into your rectum, and then the doctor will come in, he'll run some barium into your colon, and then follow that with some air. Okay, it's going to make you feel very full and feel like you have to use the restroom, but I want you to try to kind of just take some slow, deep breaths and try not to push against that enema tip if you can. Okay. Shouldn't be painful at all to you, but like I said, that full feeling like you need to use the restroom. Should you have any pain or cramping or anything that you find, you know, very uncomfortable, please let us know, and we'll see what we can do for you, okay? Okay. Do you have any questions? I do not. Okay, then I'm going to give you this gown. I'm going to let you go into the restroom here and take off absolutely every bit of clothing you have on, including your shoes and socks. You can leave your earrings in and your necklace on, it's fine. If you have a belly button ring, though, I need you to remove that. Okay? Once you're ready, the gown opens to the back. Once you're ready, just come back in and have a seat on the table and we'll get started. Okay. Just quick change orders. Okay, Miss Oates, go ahead and lay down for me. I'm going to take that first image we talked about. Now, we are not going to actually do the scalp film, so you will just talk about doing the first one. Let's go ahead and get her up here.
It's just a KUB, right?
Yes. Okay, Miss Utz, will you be okay while I go check this for you? Get out of the way. Okay, now I'm back. Okay, I showed that first image to the doctor, and he's ready for us to go ahead and get that enema tip inserted, okay? So I need you to roll up on your left side for me, and if you'll bring this right knee down to the tabletop, okay? All right. Now I put some lubricant on the enema tip, so it's going to make it feel a little cold. And I need you just to take some slow, deep breaths while I insert it, okay?
Okay.
Now you're going to feel a little pressure as I inflate the balloon. Doing okay?
Mm-hmm.
All right, then go ahead and roll back onto your back. You get the doctor. The doctor comes in. I already moved my tube's out of the way and my bucky's out of the way. Fluoro. Okay. All right, the doctor's all finished with what he's got, so I'm going to go ahead and start with my images. You still doing okay?
Oh, yeah.
Okay, good. We'll try and get you out of here just as quick as we can. Okay, so just taking a breath, blow it out, hold it out, don't breathe. Okay, you can breathe. Okay, taking another breath, blow it out, hold it out, don't breathe. Okay, you can breathe. All right, if I can get you to roll up towards me just a little bit, only about halfway, not all the way onto your side. That's good. You're doing great. You still feeling okay?
Mm-hmm.
All right. Okay. Now just again taking a breath, blow it out, hold it out, don't breathe. Okay, you can breathe. Go ahead and roll back onto your back for me. And then if you can roll up away from me about that same amount, let me grab the sheet for you. There you go. All right, and again, taking a breath, blow it out, hold it out, don't breathe. Okay, you can breathe. Let you roll all the way up on that left side for me. Yeah, I'm going to tangle you a little bit. Put your knees on top of each other and bend them, and your arms up towards your head like you're asleep.
She's such a good patient. She knows exactly what position to go in.
She is a good patient. She ought to be, she comes every week.
A couple times, right?
She comes about 5 times a week. Straighten you up just a little bit. Okay, and again, taking a breath, blow it out, hold it out, don't breathe. Okay, you can breathe. Just stay up on your side though for me. Okay, I need to put this pad up underneath you. I'm going to let you just lift up. So good. Can you scoot back just a little bit closer to me? I'm right here. Don't let you fall off. All right. That's good. Up a little.
She's too hard.
It probably was mine. Okay. All right, just taking a breath, blow it out, hold it out, don't breathe. Okay, you can breathe. Flow pattern. So, you swap out a cassette while you're giving instructions, and swap them out and so I just try to move in it.
So when we're actually confident we need to do something, do it more like that versus when we're checking off tomorrow, we're not going to be able to do it exactly like that because you're going to have to come in.
We're going to have to come in, but I want to, but you should be standing ready with that next cassette. And, and then you're going to swap out and give instruction and that kind of thing, though. Yeah, we're going to slow you down some, but when some of that swap out here and there, then, you should just be ready to go. Ready to go, ready to go. As quick as you can. Okay, come up here and look at this, and I'm now going to go through the positions. Okay, so normally you would do both decubitus images, but we're only going to do one, so, but especially...
I fell over it too.
I'm good.
Oh, I thought you pushed her.
No, I fell over it first, and then she fell over it.
It looks like she pushed her. Okay. Now, you don't want anything but her back on this, right? Because you're blocking a few.
No, it's fine. As long as we can hear you, it's okay.
Okay. All right. All I want you to think about with the when you do a decubitus is if you were doing a flat film, tube, and patient, all you've done is this. So everything you've done here flat, as far as the cassette orientation and marking at the bottom, towards the hip and all that, all you've done is turn it up so that you have a horizontal beam. So think about it exactly the same way. I'm centered at the crest. I'm centered to the middle of my cassette. I'm centered to the mid-sagittal plane. I've marked this side of her, which is her right side, the elevated side, with a right marker up at the top and down towards her pelvis. Check your collimation. I double checked by distance to make sure I don't have too much. You may or may not see any light, okay? And so, take that under consideration. We know that if your measurement is right, your distance is right, then we'll know whether or not you should see any light. This holder is adjusted so that it's fallen to the lower part of this pad, so that it falls below the level of the pad. We're using the pad because if you just place your patient on the table and then you put your cassette on the table, you will not get the downside. Either the cassette has to come lower or the patient has to come up. It's generally easier, definitely easier here. We can't drop the cassette off and have anything to hold it. Some rooms are designed where the buckies flip up and you can actually get them lower than the tabletop, and that's great. If you can do that, then you don't always have to elevate your patient. But we're going to elevate in here and we will elevate in the other room as well. This is a much bigger pad than you would normally have. Normally it would be probably about half this size. Just enough so that you got the cassette below. If you're worried about the light field or something, this is adjustable, but I would just come leave it how we have it because it's really okay. So I would do that. Be sure when you do this that your patient is straight. Notice that I put her on the edge of the pad, but the pad is in on the table some. So she's not hanging off the edge of the table. Be sure your patient isn't hanging off the table. But you want them to the back edge of the pad so that the cassette can go up as close to their back as possible. Preferably they will be in contact. She's not quite in contact, but it needs to be, I think, you need it as close as possible. Okay?
So you're centered at the crest?
Yes, centered at the crest, mid-sagittal plane, but as close to this image receptor as possible. Okay? It'll be, who's going to be in there next week? Okay, I'll tell you some things because it's a little different in there because of safety issues and stuff. But any questions about this? So just think a bit about turning a whole 90 degrees on shooting a KUB. That's a 90 degree, it's just a 90 degree shift on KUB. And we're shooting all these images on expiration, so that makes that easy. But make sure the elbows stay out of the way and that you're good on all that, okay? All right, I'm going to slide this out, take this pad out, maybe, okay, let you turn onto your back. Okay. Now I'm going to go ahead and pick up the very first one that I did and show you these positions, okay? What I had done is I went ahead and set the room up for that first image, which usually people will do their axial sigmoid first because it's the only one with an angle. Everything else is perpendicular. So when I set the room up, I go ahead and set it up with the angle for that. So I can come down here, and I'm going to go ahead. For the AP axial, you want to angle 30 to 40 degrees. We're just using it 30, and usually 30 is enough. If you should notice when you're watching the fluoro that they have a really tortuous one, then you might want to go more than 30, but definitely not more than 40, okay? I'm going to use 30. One of the things, there's a rule of thumb about maintaining your 40-inch distance, because if you ever angle more than 15 degrees and you go to center up, you have increased your distance. So the rule of thumb is for every 5 degrees above 15 that you angle, you need to decrease your SID by 1 inch. And then that actually maintains your 40 inches. So I'm going to put this at 37 inches. Okay, because I
5 degrees over
15. For every 5 degrees over 15. For this exam, and then there's some head work that we'll go over, about the only two that really affects, because we don't use it more than 30 degrees, more than 15 degrees very much. But I'm going to go ahead, like I said, I got it pulled out of the way. Angle, I got the right distance, everything's good. I'm going to go ahead and put my collimation on there. The collimation for this is 10 inches wide by 14 inches long. So 10 by 14. And I'm using the 14 by 17. I'm going to use my right marker on 14. I'm going to use 10, so I'm just going to come into this edge a little bit. And place my right marker. I want my central ray to enter the mid-sagittal plane 2 inches below the ASIS. I found 2 inches below the ASIS. Mid-sagittal plane. Just make sure your patient stays straight and they're not cattywampus. And if you're not sure, then you can always feel for both SI joints and see if there's equal and that kind of thing. All right, and then, like I said, of course, shoot this on expiration.
So the SID, do you come down on the SID or no?
I did to 37.
37, no.
I did a 37. Like I said, and I set it up that way, and then when I come to the next one, I'm going to go back to 40. What that does is allows you to use the same set of exposure factors for all your images. If you don't, then you have to know how much to increase for this one. It's way easier to do the same thing. So everybody okay with the centering and the positioning for this? Okay. I'm not going to swap this out every time. This time. I'm going to move my marker back down to just over the blocker there. And then this is just an AP abdomen. Going to come back perpendicular and 40 inches. Full 14 by 17 collimation. Just center at the crest in the mid-sagittal plane. Then just taking a breath, blow it out, hold it out. So that's just your basic KUB. Don't worry so much about making sure you have symphysis on this, just center at the crest, because you won't have, it's not like how the bladder hangs low where you're really worried about that. You're really more worried about the flexures at the top, so just center at the crest. For this one, I'm leaving the marker the same right marker, same full 14 by 17 collimation, going RPO. Let my patient roll up towards me. Bring the arm across. Be sure that the elbow stays out of the way. Now for this one, because I'm imaging the splenic flexure and it's higher than the hepatic flexure, I'm going to center 2 to 3 finger widths above the crest.
Yeah. This one is 14 by 17, right?
Yes.
You said RPO.
RPO. I'm going to center 2 to 3 finger widths above the crest to make sure I get that splenic flexure. And the centering and all will look very similar in the rotation because you need 35 to 45 degrees to your L-spine. So basically it's going to look a lot like your L-spine. Your centering is going to be kind of close to the L-spine. But just watch your light field. You don't want excessive light field on the table, but make sure you have full coverage of the entire abdomen. Okay? Hip and shoulder should still stay in alignment so that you're not cattywampus and everything looks all crooked.
So you say MSP 2 or 3 fingertips above the.
Well, not necessarily MSP. I'm really a little bit to the elevated side. If I went all the way to her MSP, then I would have a lot of light field on the table.
So kind of in between.
Yeah, like you would for a lumbar. Kind of start where you would for a lumbar and check your light and make sure it's coming over to cover the entire abdomen though. Because you may be not far enough towards the right side. So just check that. But about 2 to 3 finger widths above the crest though, to make sure you get the splenic flexure. Okay. And then when we do the LPO, we do the same thing. And here, notice how I made sure I kept her butt covered the whole time? I want y'all to do that. Okay? Because it's not as hard to remember it on a real patient because you don't want to see it. But that's important to your patient to keep them covered too. So I'm looking again, that same rotation. But for this one, since I'm getting hepatic flexure and it's a little bit lower, I can send her at the level of the crest. So I'm at the level of the crest and then coming back to include the entire abdomen again. Roughly like an L spine, but make sure you have the whole abdomen included. And then again, shoot this on expiration.
We just use the right marker.
Yeah, you can because we still have a right side because we're going to get both sides on all of these. So the right marker's okay. The only time we're going to use the left marker is for the left lateral rectum. Okay. Are we ready for that? Y'all good with this?
And this one's already to 45 degrees too.
As well. It's the same thing, just in the opposite direction. But the only thing different is we center at the crest for this one because the hepatic flexure is lower.
What's that, from 35 to 40?
35 to 45.
35 to 45?
Mm-hmm.
Okay.
And like I said, just take about the 45 and look at it like a lumbar spine. Like I said, you've done lumbar spine.
Can you turn the light on?
So just come off the MSP a little bit to each side for the PO.
Yeah, and I'm really almost, look where I am. I'm almost to nipple line. So I'm really pretty close to that. But you can see that I have light up to this side, and I'm just making sure I don't have a bunch of light on the other side of the table. Just look at it and make sure you have light covering the entire abdomen. There's not a great and wonderful single place to put those crosshairs. Okay, for this one, I'm going to ask her to roll all the way up on her left side, knees on top of each other and bent. This is basically going to be a lateral sacromococcyx. Okay, think about like the lateral sacromococcyx. I'm going to use the full 10 by 12. I'm not going to collimate down. Full 10 by 12. Mark with the left marker, and I'm going to place it at the bottom so it will be down here in the really end of the femurs usually. That's put to the anterior surface and at the bottom. Full 10 by 12. And then my centering is like it would be about for sacromococcyx. ASIS, mid-coronal plane. Find the ASIS. You can go mid-coronal plane. Just make sure again that your patient isn't rotated. And your light field still looks a little smaller, but look at my cassette. I basically included the entire boat. That lets you know that you're where you want to be. Okay. And then again, shoot this on expiration. And then while they're in this position, you would go ahead and do your decubitus.
And it was crest at MSP.
Correct.
This is a 90-degree KD.
That one's the crest or ASIS?
Decubitus.
The decubitus was at the crest. She was talking about the
My
decubitus.
bad.
This one is ASIS mid-coronal plane.
Yes.
And the cubit is going to be 14 by 17, right?
Yeah, it was 14 by 17.
You don't collimate it.
You don't collimate at all. We're not the one we're collimating on is the AT axial. Everything else is full cassette size.
Okay, and the AP axial is also the one with the 30-degree collimation. You drop it at 37.
30 degree.
And the angle.
That's what I meant.
Yeah, and then you collimate down to 10 by 14.
I'm gonna collimate it at 30.
And it's the only one you have to put the marker down and in.
Yeah, you have to move it in the sun.
Okay.
Yeah. Okay, so now I'm going to pick up and finish the exam because I would have done her decubitus and then I really would leave her up on her left side. And I'm going to ask her just to, if you stay up on your left side for me. I need to go check all these. Will you be okay? All right, and I've moved the tube out of the way. All right, go back. Okay, the doctor looked at all these and said he has everything he needs for right now. We need to let you get up and go to the restroom and get another film. So what I'm going to do is I'm going to go ahead and take out this enema tip. I would drop the bag probably straight into the trash can because that's the easiest thing to do. All right, I'm going to deflate the balloon. Oh, well, I'm going to let the barium out first. Let the barium out, so I would unclamp. Sometimes with an air contrast one or even on a straight one, they can get like an air bubble in there, and so the barium doesn't really flow back out. So sometimes you have to kind of like pump the tubing a little bit. I mean, when you do it down towards the bag, it's not that close to the patient, and just make sure that the barium has flown back, flowed back out. Okay, so I've done that. Now I'm going to release the air from the balloon, remove the enema tip, and then you go straight into the trash can with that. Okay. All right, Miss Seth, I'm going to let you sit up. I'll get you up and let you go to the restroom. Almost not. Okay. So, all right, I put some, she's not really leaving yet because we would have to come back and shoot my poster bag. I put some towels and washcloths in the restroom for you and another gown. Okay. I want you to go ahead and use the restroom and try to empty the rest of that barium out for us. Okay. And then just come back in here when you're ready, okay? And we'll get you on the table. We'll take one last image and we should be finished, okay? So she comes back. When we shoot that poster back, will you be okay while I check it? Yes?
It's just another KUV.
Another KUV. Yes.
Okay.
And hopefully she's all emptied out in it. Okay? And then will you be okay while I check it? I come back and say, okay, we have everything we need now. Okay. The doctor will read those images and send a report to your doctor. He should have it in a couple of days. Okay. What I need you to do when you leave here is to increase your fluid intake. Mm-hmm. Drink lots of water, preferably. If not water, then some kind of fluid to increase that. That's going to help flush out the rest of that barium. Okay. And your stools are still going to look white like they did today until it's all flushed out. If for some reason you don't have a bowel movement in the next 24 hours, check with your doctor and see if he wants you to take a laxative, because sometimes this can be a little constipating. Okay. All right. Do you have any questions for me? I don't. Okay, then I'm going to get you up and let you go back to your clothes and get dressed. Okay. And I hope you get to feeling better.
Oh, me too. She's probably thinking, thank God this is
over. As I would be saying, it's over.
As soon as you told me, like if I didn't know what this was, as soon as you were like, I'm going to insert this, and I'm like, no, you're not. I'm leaving. Bye.
My friend had to have one. He said, he had a colonoscopy, and then they sent him for VE, like later. And he said, I didn't know I was going to have to wait for something like that. Yeah, I didn't really tell him because I knew he probably wouldn't go.
Yeah.
And he had diverticulitis, and so they really wanted to look at that.
Yeah.
I'd still be like, no,
I wouldn't.
I'm not going.
I didn't know what it was.